Welcome and thank you for joining us in the session, Mental Health, Are We Doing Enough? Moderated by Dr. Anita Abu Bakr, President at Mental Illness Awareness and Support Association.
Assalamu alaikum and good afternoon, everyone. Thank you very much for still being with us for the second Asia Pacific Patients Congress, Patient Leadership in Health System Strengthening, jointly organized by the Indian Alliance of Patient Groups and International Alliance of Patient Organization. I'm truly humbled to be your moderator for today's session, Mental Health, Are We Doing Enough? This topic definitely resonates closely to all of us being in this pandemic of COVID-19. And for me as a person with lived experience and a mental health advocate, it is of deep concern that mental health is to be addressed with the highest urgency to ensure that this pandemic doesn't lead to a mental health pandemic as well. And so this is something that the government and policymakers will need to prioritize. It is deeply frightening as the challenges are manifold and multifold. It causes loss of lives, the economy is in deep crisis, and so is the mental health of all. In Asia Pacific, COVID-19 has had a direct impact as most mental health services and psychiatry care were restricted or collapsed or not considered as part of essential services during the height of the pandemic. And this is true for Malaysia as well, where I come from. And looking at how things have unfolded since the onset of COVID-19, and for the most vulnerable, it has been more challenging as many are not able to access, as we know, health services, treatment, medication, from personal assistance to support getting food. Many have lost jobs, safety were compromised for those, especially in prison, nursing homes, psychiatric hospitals, those on the streets and more. And so, as the unprecedented COVID-19 crisis continues to wreak havoc across the world with the most, as mentioned, vulnerable suffering, the task of eradicating poverty and achieving development goals is more challenging, urgent, and necessary. So the question begs to what can be done. Are we doing enough? Are our systems in line with the recovery model and approach? We're putting the person at the center of care. How do we move from here? For this, it gives me great honor to introduce our three esteemed speakers for today's discussion. Dr. Kanan Subramaniam. Oh, I apologize. Dr. Phil Gia Season is not able to join us today. So we have Dr. Kanan Subramaniam and Dr. Nan Kumar. Happy to have all of you here today. Please allow me a couple of minutes to introduce each speaker before we begin. Our first speaker is Dr. Kanan Subramaniam, who is the Senior Medical Director of Vitrus, formerly known as Visor Upjohn. He is a physician with specialist training in psychiatry and has been leading the NCD strategy in emerging nations for Vitrus, empowering people worldwide to live healthier. I'm happy to read that he strives to foster patient centricity and was previously leading a biodiscovery venture for Fonterra. Welcome, Dr. Kanan. Nice meeting you virtually. Our second speaker, Dr. Nan Kumar, is a professor of psychiatry and professor in charge of neuromodulation and mental health. He has more than 20 years of experience as a clinician, a researcher with interest in community mental health and also spirituality. We need to have coffee virtually after this, Dr. Nan. Interested in spirituality. And Dr. Nan has delivered talks in various national and international conferences and published scientific papers in reputable international journals and does education talks regarding health on all India radio and national television to improve awareness on mental health. He shared with us earlier as well on how he has created or formed, I think it's the Mental Health Foundation, and has also created a e-magazine in Hindi language, where he emphasizes that the articles are contributed by caregivers and also peers, not much from psychiatrists. So welcome, Dr. Nan. Thank you for being with us today and hope all is well. Okay, so before I hand the floor to Dr. Kanan, for those that have any questions, you may post your questions on the Q&A box, and please mute your mics for a smooth session. I would like to welcome Dr. Kanan to share on the impact of the pandemic on mental health and well-being of patients with us and some good practices that can be implemented during this time. Dr. Kanan, the floor is yours.
Thank you, Dr. Anita. Thank you for that introduction. And it's my privilege to be part of this esteemed panel, along with Dr. Nand and yourself and Dr. Nand's colleague, who will talk to us a little later. I just want to create an introduction about mental health issues that are occurring during the pandemic. So let me get straight into it. The pandemic, or the health footprint of the pandemic, can be best described in phases. So we had the first phase where there was the immediate mortality and morbidity of the COVID-19 itself. And then the second phase where there was the impact of resource restriction on urgent non-COVID-19 conditions. And this is an important aspect because as we know, people with chronic illness were more susceptible to a prolonged and more severe illness with COVID-19. Then there was the third phase, which is the impact of interrupted care, particularly again on these chronic conditions. So not only was the COVID-19 serious in these chronic conditions, but also care for chronic conditions was interrupted. And now, we're well into 12 months post COVID-19 when it started. We have the psychic trauma, not just from the COVID-19 itself, but from the measures that we have taken to reduce the impact of COVID-19, includes the economic injury. But let's not forget, people who already have mental illness are further susceptible to this. So it's that phase that we're going to talk about a little bit more. This was a study that came out of Australia about what's stressing us most. And you can see that people were really, really worried about economic issues affecting them during COVID-19, losing their job, paying bills, and also the being part of a community, not seeing family, not feeding the family, not seeing friends was a big issue. In New Zealand, the University of Auckland, Dr. Felicity Plunkett-Smith also conducted a survey of general practice, and found that initially there was a report of decrease in patient volumes in mental health, which was actually happening because fewer people were going to see doctors. But then towards the latter part of the pandemic, there was a reported increase in mental health presentations. And along with a reported decrease in wellness and chronic care visits. So this really sets us up for some serious issues that we have to face as the pandemic goes on and wears out. And let me take you to a couple of data points. This is from Statista, where there was a share of adults who experienced mental health problems during the pandemic in different countries. And these are all high-income countries, as you can see. And there was a widespread impact on mental health. And pandemic caused a spike in anxiety and depression in the US. So you can see in the orange, this was prior to the pandemic in January, June 2019. And in May, it more than doubled, where the symptoms of anxiety disorder, symptoms of depressive disorder were coming through. So this is the palette where the picture is being painted of mental health issues coming through from the COVID-19. But let me take you to an overview of other chronic conditions. So I'm going to give you some slides, some stills from a movie that was put through by the NCD Alliance. As I mentioned, NCDs or chronic conditions make people more vulnerable to the dangers of COVID-19. While COVID-19 makes headlines, the hidden pandemic of NCDs still races on. So, which includes diseases like cardiovascular disorder, diabetes, cancer, chronic respiratory illness, but also mental health issues. Now, mental health does not cause mortality like the rates of death, but certainly disability. It's the highest contributor of disability in the world. And unfortunately, COVID-19 is going to also increase perhaps mortality. This is Dr. Lim Kroy, who was actually part of this video. She's the Chief Medical Officer at the Sihanouk Hospital in Cambodia. And she was going to tell us what are NCDs. They are non-communicable diseases. After COVID hit the world, most of her patients felt really, really vulnerable. They worried about COVID-19. They worry about, will it affect them? Will they be able to put food on their children's plates, etc.? So with COVID, fear and anxiety were increasing as well. Now, fear and anxiety itself needs to be managed before it blows into mental health issues. This is a very difficult moment for us, but it could also be a significant opportunity. We can actually get together, we can build back better. And I think that's the name of the game right now. We need to build back better. COVID-19 has shone a light on health systems worldwide, and NCDs must be built into the health system responses to actually manage COVID-19 and be a part of the advances in universal health coverage, which is really, really important as we go forward. As I mentioned, those were stills from a movie made with the support of the NCD Alliance of Civil Solidarity Fund and contributed by other organizations as well. I just want to let you know about the pressing issue, because this is something that we cannot forget. There are trends in suicide during the COVID-19 epidemic, which is an editorial in the BMJ just last month. There were concerns that rates of suicide might increase, or actually have already increased, because a deterioration is population mental health, higher prevalence of reported thoughts and behaviors of self-harm among people with COVID-19. And of course, as I mentioned, the problems with accessing mental health services. Evidence suggests that previous epidemics, such as the SARS in 2003, were associated by deaths by suicide. Modeling of this effect of COVID-19 on suicide prediction ranges from 1% to 145%. So you can see the science is not exacting here, but there are reports coming through. But the folks who wrote this paper just actually suggest some caution, because the supposition is no replacement for evidence, right? So in June, there were no robust epidemiological studies with suicide as an outcome. So while we must remember that this can be a serious outcome, we need to be very, very careful that it is happening. So we need to really put into practice some measures that can prevent the outcomes. And one of the things we've used successfully is psychological first aid, or PFA. Now, the World Health Organization has put together a guide for field workers, and the guide covers psychological first aid. And I just want to talk to you a little bit about what psychological first aid is. It is providing practical care and support. It does not intrude. It assesses needs and concerns. It helps people to assess basic needs: food, water, information, listening to them, but not pressuring them to talk. And it really helps when community workers like teachers, general practitioners, doctors, nurses actually adopt the psychological first aid for their communities. But it is also important to understand what PFA is not. It is not something, as I mentioned, that only professionals do. Care workers can actually do this. It is not professional counselling. It is not psychological debriefing, right? In that it does not necessarily involve the detailed discussion of the event. It's really about how they can actually manage life as we go forward. So although PFA involves being able to listen to people's stories, it's not about pressuring them to tell you about their feelings and reactions to an event. This has been actually used in various circumstances. For example, I was using it during the Boxing Day tsunami in 2004, when Sri Lanka, there were about 2,500 deaths, and close to 300,000 people were displaced. And psychological first aid prevented the post-traumatic stress disorder that could occur afterwards. Dr. Nankumar, who's going to speak after me, actually has used this with correctional facility inmates in Tihar. And so therefore we found that psychological first aid can actually prevent serious mental illness from taking a hold of people. But what's more important is, before we can even implement psychological first aid, coping with COVID-19 is very important. It's important that we take breaks from the news. It is important that we take care of our body. Going for walks, playing outside with kids is very important. Taking the time to unwind is important to clear your head of these things. Connecting with others. Utilizing the Zoom type activities, you can actually talk to people far away. But also setting goals and priorities is very important, and focusing on the facts and not the myths that are created. So I think we can do a lot to cope with COVID-19, but also with things like psychological first aid, we can prevent serious mental illness from occurring. So with that, I'd like to thank you for this opportunity to talk to you about the mental health sequelae of COVID-19. And are we doing enough? Perhaps not. And we need to really think about what we can do better. Thank you, Dr. Anita.
Thank you very much, Dr. Kannan. Beautiful slides, amazing pictures. Thank you very much. And of course, a great presentation. Okay, so without further ado, I would like to now invite Dr. Nan Kumar to share on the impact of COVID-19 on the psychiatry care in India and how and what can be done to address the mental health problems through effective psychiatric care system strengthening. Dr. Nan, over to you.
Thank you very much for the opportunity to speak at this platform only for the patients. And thank you, Dr. Kannan, for such a wonderful insight into the COVID thing. Just let me open my slides. My slides are visible.
Yes, they are visible.
Visible?
Yes, they are visible.
My slides are visible? Okay.
Yes.
Thank you. Good. Thank you. So, as Dr. Kannan has mentioned, mental health, are we doing enough? Perhaps no, we are not doing enough. And I just did this search, PubMed search, just yesterday only. And I think we have been doing a lot in terms of research. 4,000 articles the people have published within 1 year, only on COVID and mental health. So if you put a keyword, COVID and mental health, you'll find 4,000 plus articles. And this is only for the PubMed. Forget about other index, other online journal search engines. So that means it must be at least 5,000 articles. So that simply means that we are publishing in COVID and mental health for at least 10 to 15 articles per day since the COVID started in December 19. And these all research articles, what they reflect that what Professor Kannan has mentioned, which is substantial increase in anxiety, depression, substance abuse, loneliness, domestic violence, PTSD, panic attack, and of course suicide rate, that what you have mentioned. We don't have data by this time of suicide, but perhaps it has increased and it is increasing. Here in Delhi, in the beginning of the COVID-19, in February, March, we have noticed at least 5-6 suicide nearby in the hospitals. So it's a major issue that we are going to perhaps face. So at least in terms of research, we are doing something. And if you look at all the research, 4,000 plus research, and if you look at the systemic review of all this, majority of research are being focused on the person not affected with the COVID. So not the COVID patients, but the other person, the community. So main focus of the research, what the people have done with the community, not the COVID patient. Like in this review, what I have seen, out of 43 studies, only 2 studies have focused on the COVID-19 patients, and they reported some post-traumatic stress disorder, and of course, higher level of symptom for depression. But still, they pointed out, the researchers pointed out that we need to do more research to understand the mental health problem. So with 5,000 publication or so, still we are not able to understand what actually the problem is, except like anxiety, depression, PTSD, panic attack, and suicide. But I feel mental health is much, much bigger than that. A lot of psychological distress that we can't cover under DSM-5 and ICD-10, but it's a major issue. It doesn't come into the criteria of diagnosis what we have been using. It's a major. And it is very, it's not uncommon. All the disaster and pandemic, they have association with mental health problem. Like in hurricane, US hurricane in 2008, 5% of the population affected by hurricane, they showed depressive symptom. In the post September 11 attack, a lot of depression was reported, and increased use of alcohol was reported in 25% of the person in the post-September 11 attacks. So these mental health problems are very, very common after any pandemic, epidemic, or any disaster. But this pandemic is different. I feel very strongly why this pandemic is different, because this pandemic was first reported in December 19, and in this pandemic, social distancing was introduced as a vaccine, as almost social vaccine or no non-medical vaccine for the prevention of the COVID-19. And these social distancing, I think, that has perhaps impacted very, very hugely uh, across the world, because this social distancing, including the lockdown also, that changes the behavior pattern, of the entire global population, and that has led to lot of mental health issue, perhaps that we are not able to realize at this point of time, because we don't have to actually system to measure it. I'm sorry, I'm using this system to measure it, because actually we can't measure it, because we have to develop some scale, something like that, because we can't fit this into the DSM and ICD-10. This is my personal understanding. Now, social distancing is why it is so bad, because if you look at the mental health support group, like APC support group also, this all depends upon the social connection and social support. All the mental health program that depends upon the social support. And this social distancing is basically antithesis of all that is considered therapeutic in mental health. And to begin, further, like in forced quarantine, then social isolation, distancing within the family. Like if you look at the messages given by the radio, television, and social media, like within the family also, you should sit separately, you should not talk much, wear a mask. So a lot of things, that perhaps this kind of messages that we conveyed unknowingly or knowingly, and that has impacted very, very hugely. And we all know that as a medical doctor, perhaps we know that social connectedness and need of social uh, being is very hardly wired into our brain. We are developed to live in a society, not in isolation, and hence social distancing takes away lot of like warm support, collective meaning making in society, and that is what is mostly required if you want to deal with a pandemic or epidemic or any disaster. So that has perhaps affected very, very hugely. In addition, what Dr. Kanan has mentioned, like mass employment, depletion of support network, problem in the housing, and sanction on social and cultural gathering, that is still it is going there. They are very fertile ground for any mental health problems to occur. And recently, I have seen a just article just published 10 days back only. This need for social behavior is as keenly experienced as that of hunger. So hunger and social behavior is change. And if you look at the infographic by Dr. Kanan, the 77% people, they ask that they're missing the friends and the family. And 40%, approximately 40%, they were concerned about the job loss. So this was perhaps more important. And this is the article I was mentioning about, just published on November 23. What they observed, the neuroscientists observed that there is a longing for social interaction felt during isolation, similar to the food craving people experience when hungry. So this is they have proved by the functional MRI, in fact, and this is so recent. So that is the important social distancing that is affecting a lot of our mental health issues. So what has happened was, as Dr. Kanand also mentioned, our public mental health services was not good from the beginning also in terms of mental health, not in terms of the COVID-19, and of course NCD also. So already overburdened public mental health services got more overburdened, and I would say it is almost collapsed in this beginning of the pandemic. For example, in our hospital in Delhi city, in the state, almost all hospitals were closed for at least 1 or 2 months at the beginning in terms of mental health services. Even the emergency services, for a stroke patient, for other patients, they were also not running. So the services and this, so almost collapsed. So we had a lot of difficulty, including the emergency system. We're not entertaining the patient with mental health problems. just only for COVID-19. Majority of beds were oh, devote, given to the COVID-19 facility. They were reserved for that. So the services were running just notionally or perhaps no negligible access to emergency care was there. And the private clinics also they got shut down. They were not working almost working for very few hours or so. In the beginning, that was total shutdown. Now we have restarted the clinic, mainly the online, digital online, and very few offline patients were able to see that. So what we have done, in fact, in the last this 9-10 months, we have perhaps explored more about video conferencing, telephone call, social media, sharing of the information, news. Then information suggests that this could be a good alternative that we have done, perhaps no. And we have also perhaps started online gymming, yoga studio, worship, like lot of temple also in India. Now there is online puja that being performed. Actually, it's good that you are getting connected to the God and perhaps superpower, and that's a good coping mechanism. I think the God is best coping mechanism that we can think of. And a lot of virtual spaces are being created, virtual works spaces, virtual office, and so many things. And perhaps we are trying to look the things in a very very different way. And we feel that COVID-19 is not going to be over for so many years, and we are investing a lot. I don't know, not what will the thought process after few. I will just request Suhasini to give just 2 minutes to us to mention about this slide because he has helped me in that. Dr. Suhasini, can I request you, please?
Thank you so much, sir. So now I'll be shedding some light on certain initiatives or programs that were started at three levels: government level, like basically the national level, state level, and followed by what civil society organizations were doing for the same. So to start with, a toll-free helpline for providing psychosocial support was started by the Ministry of Health and Family Welfare in collaboration with NIMHANS Bengaluru. A national health portal was also launched earlier in October by the Union Health Ministry, which aims to establish a single point access for authenticated health information. Helplines were further set up for all 28 states and 8 union territories for all kinds of help, including psychosocial support. Union Health Ministry further released directives for taking care of mental health of different sections during the COVID-19, seeing a massive rise in cases of domestic violence across the world, including India, sexual assault cases, and cases of abuse and violence towards children. The National Commission for Women started a helpline for providing psychosocial-emotional support to women in distress and survivors of domestic violence. It also launched a chat-based helpline operated through WhatsApp for women in distress. Apart from that, several other the civil society based initiatives include My Hope, the one already mentioned by Dr. Nand, that was started by Mental Health Foundation. It's a national portal dedicated solely to mental health that provides free of cost consultations through to psychiatrists, psychologists, counselors, and wellness experts. Project Mumbai was another such initiative that made a team of 15 counselors, trained them, that provide free of cost therapy and operate 7 days a week for 12 hours each day. Jamia Millia Islamia, educational institution in Delhi, started a pro bono counseling service for their students, teaching and non-teaching staff. And lastly, several artificial intelligence based initiatives such as apps like Headspace, InnerR, WhatsApp provided free premium subscription to their guided activities and mindful meditation based exercises during the lockdown period that has helped several lakhs of people across the world. Thank you.
Oh, thank you, Suhasini. So we have done a lot, in fact, but we have not seen the effectiveness of all these measures. No, but if you look at the research part of this, recently people have done some research work, and what they have mentioned that these programs are effective. Not those programs I have mentioned, but any program that is a systematic program like CBT for the health worker, they are effective, and they have done the follow-up also, and at 3 and 6 months follow-up, if you do the CBT, like some structured program for any community or health workers, it could be effective. So we can think that whatever we have done, this could be effective, but we have to look into that. how sincerely perhaps we are doing all this. So have we done enough? Uh, I think I will agree with Dr. Kanan. Perhaps we have not done enough. Like, no, there are a lot of structural changes, challenges like dearth of professional, absence of insurance coverage, treatment gap is already existing, and that has no gap has become further more and more, and there is a restriction to access to the mental health services, whatever is available, is it there? And so little has been done, perhaps at policy level also, because if you look at the way we have started the pandemic management, so perhaps that component was missing. The mental health component was missing, and I feel that it is a first component that should be included, because majority of the pandemic and epidemic and disaster is related to the people's behavior, and we have to be very very careful to understand what kind of messages we are giving to the people and how they are going to react for with those messages. So that is very very important. So I don't think that no, we have not we have done enough, and whatever we have done, no, not at a very desirable pace. We need to increase our pace. We need to be more systematic. But at the outset, no, at the positive outset, what I can share this, that this pandemic might act as a springboard for our significant growth in the mental health sector. And I think same thing Professor Kanan has mentioned. So way forward, I think no, the till this social distancing is there, the telemedicine outreach that involves voice and video is definitely better than the text and other thing. Then there should be extra effort to ensure connection with the people who are what we call marginalized. But I feel that everyone is now marginalized, no, at least socially. So we need to be connected more and more by different means that we have to perhaps explore. And I feel that there should be national level psychological first aid for no such kind of pandemic. That simply means the right kind of information should be made available to the people, so that they should understand that is this anxiety is a common, this no low mood is a common, and no they have to understand the acceptance of this and how to deal with that. This then for mental health professional, I think the way forward is to that they should look into the no social issue also alongside the intrapsychic, cognitive, and behavioral aspect of the mental health. So these are important things. So I will finish with this concluding remark. Like Franco Basaglia, he's an Italian psychiatrist, and he said that social body is sum of subjects who participate in their own social organization and respond to their needs and those of the they are staying with whom. And what he envisaged that no restoring the social body of the people who are marginalized or who are no mentally not healthy, it is a utopia for modern mental health reform. So sooner we go to the social restoration, I think the better we can manage lot of mental health issue. And this is no uh, this is with this I would like to finish. And we might be gradually and successfully dealing with this physical implication and the pandemic, but of course, sorry, we are going to deal with this mental health epidemic also. And I think we can manage that, because kind of program that we are doing, like IPCC and all, I think with together perhaps we can make some remarkable dent. Thank you very much. Thank you.
Thank you very much, Dr. Nankumar. We would like to then open for question and answers. And again, those of you that have any questions, you may post it in the Q&A box. I think we have about 10 minutes to go through a Q&A. I think Dr. Nan and Dr. Kanan, thank you very much. I think it's very interesting, the points that were presented, especially on how the current public and mental health services was severely overburdened or maybe nearly collapsed, as Dr. Nan mentioned. I have to say, in Malaysia, the challenge in the beginning was because mental health services was not considered an essential service. And so because of that, a lot of psychiatric units, clinics, mental health NGOs in the community, we were not able to operate physically. So a lot of appointments were canceled. A lot of people were not able to access treatment and mental health services. And so this was how the quantum leap happened for many of us, where we had to migrate everything online. And I think this is what we have learned. And what is also interesting is, as Dr. Kanan mentioned as well, throughout human history, be it the pandemics and epidemics, people have fallen into anxiety and depression, and suicide risk increased, suicide rates rocketed as well, and people were resorting into harmful or unhealthy coping mechanisms, be it alcohol, recreational drugs, heavy smoking, etc. And today, when this pandemic hit us, we were not prepared, even though it has happened before. So again, have we done enough or not? So I am going to the first question, which is, mental health is considered a hidden pandemic. How can patient groups draw attention of policymakers to this very urgent issue? This is for Dr. Nan Kumar.
Thank you. I think it's a very relevant question. We need to draw their attention because, as you have mentioned, in Indonesia also, mental health is a primary health services, it's a component. So everywhere it is a primary health services. In India also, we consider mental health as a part of primary health care. But practically, perhaps there is some changes. Some things are not that good at the ground. So I think the best way to draw their attention is to make them aware in the way that they understand. I mean, the policymakers. For example, if you keep on talking about the only stress part, they may not be able to understand, because stress is very, very common for them, and they love to have the stress. So perhaps we have to project something like the combined model of biological, psychological, social, epigenetics, and how it affects the brain. And when their family, or when they are near and dear one, they develop illness, it's the best time to sensitize them, perhaps. And it happens, and it works. This is what I think.
I think, if I may, Dr. Anita,
Go ahead.
One of the most important things you've asked, how do we make policymakers talk about this? But before I talk about that, I'd also like to talk about the community spirit. Dr. Nandkumar and I also said that loneliness, not having connections, is a great impact on people,
Yes.
not only people with mental health issues, but even those who do not have mental health issues but are impacted by the pandemic. So I'd like to take this opportunity to congratulate you, Dr. Anita, that what MIASA did during the early phases of the pandemic was an amazing initiative that should be copied around the world. You used social media to the advantage of bringing people together and talking about issues. I think that should be copied right throughout the world. And we can do this with the tools that are available right now. So that was a wonderful thing that you did to bring the community together. Now, with the policymakers, one of the things we know, and the chair of IPO, Dr. Ratnadevi, has mentioned this before, what makes governments look up is when there's cross-border risk to economies, risk to health scares. And when there's a cross-border risk, people immediately do things to enact policy to prevent that risk from happening, particularly to the economies. And I think through avenues that are available, we should actually talk to people. Mental wellness is actually economic wellness. So I think that's the way we need to sort of present it to governments. And may I take a point to talk about, in the Asia Pacific Economic Community, which is a collection of 21 countries which gather together to look at how they can actually support the economies, 21 economies. They have a mental health hub which has been established, and they do some work to make sure the ministers of health understand that mental wellness, in fact, health is important to wealth. And I think that's a very important part that we should actually take forward as well.
All right. Thank you. Thank you very much, Dr. Kanan. Very good point. Okay, let me see if we have more questions. Okay, there is a comment from Dr. Kamal. Honor, respect, and regards to the organizing committee, all of praises only for the Almighty God. So I think that is all of the questions that we have for today. So I will wrap it up really quickly here. And yes,
Dr.
Dr.
Nida,
Nan?
could I just pose a couple of questions I'm picking up from the chat on the other
Oh,
side?
yes, please.
So what I think it's a question of both at a community level, how do we train traditional healers and service providers in ensuring that we take out the so-called exploitative elements of it. How do you see this? And as you know, in our culture in the subcontinent, we have many rich traditions of dealing with mental health at a spiritual and community level. So that could be answered, say, by yourself for a start. I think you mentioned very clearly when Malaysia has a very rich tradition that we can go back to. And this is especially if the absence of psychiatrists. As you know, in many cases, you've got one psychiatrist for about 2 million people. So where do they go to? You know, it's a first aid of a kind. Please do say something on that. Thank you.
All right, thank you very much, Kawaldeep. I think it's very interesting, coming from, Malaysia, our culture, the Islamic religion as well. A lot of the Muslim people, not only, the Malay or the Chinese and also the Indian, would go to a spiritual healer or religious leader first before actually going to see a psychiatrist. And so what happens a lot is they will also see a shaman. And then this is where it becomes really ridiculous, right? And so there is a huge gap in mental health literacy, obviously. And so what we have done is, especially in the works of Miyasa, our spiritual healers in Miyasa are trained in mental health. So they are very well versed in mental health. So this is where we're not going to blame mental health to black magic, or those kind of disturbances, etc. And going through this training would be very important for us to be able to assess if the person is truly having a mental health condition, or it could be a spiritual condition as well. So this is how we have been doing it in Malaysia. But of course, the challenge is, Kawaldeep, is there's no a governing body for spiritual healers. So that remains the challenge. So as much as possible, I think what needs to happen is education. We have to be educating people on mental health. That is the only way where false or how do we say, people that are not like shamans and people that are not well trained in will not be involved in the mental health space. So that's what we're doing currently.
Yeah, thank you very much. Reason why I asked this, because I'm from Kenya and I know that in African health systems, especially in South Africa, the sangomas were brought in to trained in primary healthcare, recognizing symptoms and recognizing what can be done, what can't be. And they were certified. There was a certification system going on.
I see.
So, yeah, this is what can, and maybe that's something for policymakers. I don't know, Ayush could be. I don't know if Indian Nationals, Nand Kumar or Sushani can say something. Maybe you could introduce that yourself.
Oh, Ayush. Ayush, I think Ayush, they are doing, in fact, no, but it's more towards the yoga, Ayurveda. So it's something like what we call primary prevention. So that Ayush is doing. In fact, one more aspect that we need to cover is that mental health at a school level. And actually, we should focus on the mental health at a school level. And for that, we have started a program called MATE. MATE is basically, MATE means no friend, support. And MATE, the full form is mind activation through education. So we are working on the basically resilience and flexibility, and the focus, concentration, and how the brain works, the effect of food on the health. No,
Okay.
these small
Okay.
things.
Thank
For
you
class,
much. I think I've been given a notice that we need to end this session. Thank you, Dr. Abubakar. Thank you, Dr. Subramaniam, Dr. Nankumar, and also Sushani. Thank you for joining us on this. Thank you and have a nice day and keep us up.
Thank you very much.
All right.
Thank you.
Okay. Thank you very much, everyone. Bye-bye.
Thank you.